This video will cover the basics of cardiovascular autonomic dysfunction in Parkinson's disease and considerations for exercise programming for these patients. The information covered in this video includes a general background about cardiovascular autonomic dysfunction in people with Parkinson's disease, how this dysfunction influences exercise, and ways to manage and modify exercise programming in people with this condition. The objectives of this video are listed here, with the primary goal of improving your ability to identify an altered response to exercise and adjusting exercise programming for individuals who may have impairments in cardiovascular autonomic function. For a more in-depth overview of how to screen, evaluate, and treat neurogenic orthostatic hypotension, please refer to Lenny Swenson's informational video for more details on orthostatic hypotension in this population. The primary clinical manifestation of cardiovascular autonomic dysfunction in Parkinson's disease is neurogenic orthostatic hypotension, which is a type of arterial baroreflex impairment that results in a significant drop in blood pressure when transitioning from lying to standing. This impairment is directly related to PD pathology and influences both central and peripheral aspects of the autonomic nervous system. When supine, central blood volume is easily maintained and cardiac output is sustained by readily available venous return of blood to the heart. Transitioning to an upright position causes a gravity-induced shift of blood volume to the lower limbs, which causes a drop in blood pressure. In a healthy response, the arterial baroreflex detects this drop in blood pressure and responds with increased heart rate, cardiac contractility, and sympathetically mediated vasoconstriction in the limbs to redirect blood flow back to the central cavity and maintain perfusion to essential areas like the heart and the brain. It is important to note that in those with a neurogenic source of orthostatic hypotension, the heart rate response is blunted in addition to this drop in blood pressure. The lack of a heart rate increase, in addition to impaired vasoconstriction of peripheral arteries, produces the large and often sustained drops in blood pressure. The prevalence of neurogenic orthostatic hypotension has been estimated anywhere between 30 and 60%, with a common estimation of about 50% of people with Parkinson's disease. The presence of neurogenic orthostatic hypotension increases with disease duration and can be present even in the absence of symptoms. Key impacts of neurogenic orthostatic hypotension in this population include negative influences on outcomes such as activities of daily living, falls, and healthcare costs, but is also a contributing factor to exercise intolerance and is associated with greater levels of fatigue. Most importantly, data suggests that survival probability is significantly lower in those with orthostatic hypotension compared to those without orthostatic hypotension in this population. So the effect of arterial baroreflex impairment extends well beyond the presence of symptoms or lightheadedness when standing that is often thought of with orthostatic hypotension. The arterial baroreflex is one of multiple neurological reflexes that is involved in coordinating the cardiovascular response to exercise. Although the coordination of this response is influenced by many pathways, this video will focus specifically on how impairment in the arterial baroreflex for people with neurogenic orthostatic hypotension influences the cardiovascular response to exercise. At rest, the arterial baroreflex operates around a set arterial pressure that is monitored and adjusted in a feedback manner through changes in heart rate and vascular tone. During exercise, the arterial baroreflex experiences a resetting process where the allowable systemic blood pressure is increased in order to improve blood flow and oxygen delivery. As exercise intensity increases, a higher heart rate is required to produce increases in cardiac output and delivery of oxygen to the muscles. If the necessary adjustments are not made to the arterial baroreflex set point, the cardiac output produced would be inadequate and can lead to early oxygen deficits in the muscle. Symptoms of this process include early fatigue, lightheadedness, and can be as serious as ischemia or syncope. The curves in this graph illustrate the resetting concept by providing a range of carotid sinus pressures at any condition, in which as pressure decreases, heart rate increases, and as pressure increases, heart rate decreases. During exercise, the demand of active muscle requires an increased cardiac output and oxygen delivery, which requires an upward shift to the baroreflex curves and provides a higher allowable pressure to meet the higher metabolic demands of exercise. And this is done in an intensity-dependent manner, in which higher intensities require a higher shift in that curve. In people with Parkinson's disease, the presence of a blunted response to exercise at various intensities has been identified. When compared to healthy controls, the heart rate response is typically lower in Parkinson's disease, even when relative workloads are compared. This is commonly accompanied by a blunted blood pressure response as well, and is attributed most often to PD-related sympathetic impairment. Recent studies have also looked at the response to exercise testing in early Parkinson's disease, in which about 13% could not achieve greater than 85% of their age-predicted maximal heart rate. This suggests that even those with relatively short disease duration can be affected by cardiovascular impairments of Parkinson's disease. With this in mind, age-predicted maximal heart rate would likely be higher than achievable in a significant portion of people with PD and may not be an appropriate use for certain individuals with Parkinson's disease. With the understanding that many individuals experience altered cardiovascular responses to exercise as a result of Parkinson's disease, how do we use this information to inform exercise programming? It is well documented that exercise is essential for improving outcomes in people with Parkinson's disease, and while more research is needed to understand the mechanisms and relationships between Parkinson's disease progression and cardiovascular impairment, identifying those who may experience exercise intolerance as a result of autonomic impairment is essential to improving outcomes in people with PD and avoiding the deconditioning fatigue cycle. While the evidence in Parkinson's disease for understanding the autonomic influences of autonomic dysfunction on the response to exercise, chronic exercise training models in other populations, such as dysautonomia and diabetes, report positive benefits to measures of cardiovascular autonomic function over time that reinforce the importance of exercise in this population specifically. If you are prescribing exercise in people with Parkinson's disease, identifying neurogenic orthostatic hypotension can provide insight as to whether their autonomic dysfunction will influence their heart rate response to exercise. And so screening and evaluation of neurogenic orthostatic hypotension is key. In those with significant autonomic dysfunction, a slow progression of exercises may be necessary and is best modeled by the dysautonomia protocols, such as the CHOP protocol for postural orthostatic tachycardia syndrome. This type of protocol involves decreasing gravitational stress with recumbent or supine exercise for the first 3 months. Consistency and slow progression is key, as well as monitoring symptoms during exercise. Although age-predicted maximal heart rate is likely inaccurate for these individuals, monitoring heart rate during exercise and providing patients with targets associated with a rate of perceived exertion can help improve exercise intensity over time and track progress. It is important to note that those with severe symptoms of neurogenic orthostatic hypotension likely have higher levels of deconditioning in addition to their autonomic impairment, which can compound exercise intolerance and should be considered during exercise programming. Patience in this process is essential for improving conditioning while not eliciting symptoms. In summary, neurogenic orthostatic hypotension is a clinical sign of cardiovascular autonomic dysfunction in people with Parkinson's disease that can affect patient outcomes and is often associated with an altered response to exercise. However, there are strategies that can be applied in these individuals to help improve exercise tolerance and improve outcomes in these patients.